Hello everybody. Today we are going to discuss about Vexus. Vexus proves the valuable in individual with the suspected volume overload, heart failure, and hemodynamic AKI, shock state, or unexplained hypotension, spanning various care environments such as intensive care unit, inpatient floors, and ambulatory care set at and in ambulatory care set. It is crucial to emphasize that while Vexus offers valuable insight into hemodynamic status, it should not be substitute for careful history taking and traditional physical examination techniques such as assessment of capillary refill time or neck vein examination. Instead, it should be integrated into clinical context to enhance patient care and inform treatment decision. About preparation before initiating Vexus examination, universal safety precautions should be adhered to and appropriate protective care should be worn in accordance with the institutional guideline, taking into account the patient's location and the infectious concern. The patient should be positioned in the supine position and the examination table should be adjusted to the operator waist level to ensure optimal scanning condition. Throughout the procedure, the probe should be handled with one hand while the ultrasound machine should be operated with the other. Now about equipment, Vexus requires the ultrasound system with the two-dimensional image display and Doppler capability, specifically color and the pulse wave Doppler. Either phased array or curvilinear transducer is suited for this purpose, though depending on the patient's body habitus, the use of both may be necessary. For instance, in our experience, the curvilinear transducer is more effective for picking up flows when performing renal Doppler in the critically ill patient. It is recommended to have ECG module connected to the machine for simultaneous ECG tracing with Doppler waveform to facilitate accurate interpretation. With handheld ultrasound device can be utilized. There is a variability in their image quality and it is advisable to opt for high-end device where resource permit. Furthermore, handheld ultrasound device typically lack ECG capability. Ultrasound transmission gel and glove should be readily available as with any ultrasound examination. Now, examination of the iris. The first step of the Vexus is to evaluate maximal diameter of the iris. Place the transducer 1 to 2 centimeter below the xiphoid process with transducer orientation marker at 3 o'clock, capturing IVC in its short axis, though lever as an acoustic window. Adjust the transducer closer to the xiphoid process in case bowel gas impedes the view. The abdominal aorta is in the midline, separated from the liver, while IVC is situated to the liver within the liver tissue. The transition to the long axis view by angling the transducer towards the patient right to the center of the IVC and then rotate the transducer counterclockwise 30 degrees from 3 o'clock to 12 o'clock. This rotation enables the visualization of the long axis of the IVC, joining the right atrium and hepatic vein draining into the IVC. Some users prefer the image the long axis view first, which is accepted. Now the first figure is demonstrating hand and the probe position for the IVC short axis view with the transducer orientation marker set at 3 o'clock. Second image is showing the hand and probe position for the IVC long axis view with the transducer orientation marker set at 12 o'clock. So IVC short axis, first figure is demonstrating IVC short axis view. Second figure is demonstrating IVC long axis view. Then this figure is demonstrating the measurement of IVC in the short axis view. The another figure is demonstrating the optimal measurement location of IVC in long axis view is either 2 centimeter below the right atrium IVC junction or approximately 1 centimeter below hepatic vein IVC junction. About interpretation, in Vexus, IVC maximal size of less than or equal to 2 centimeter corresponds to the Vexus grade 0, indicating absence of systemic congestion. However, caution should be exercised when applying this threshold to population beyond the conventional Western demography, as an adjustment to 2 centimeter threshold may be necessary. Identifying IVC that appears plethoric and exhibit more or less circular shape in the short axis may be more appropriate. Now, for potential pitfalls, IVC may be confused with the adjacent aorta. Identifying abdominal aorta by observing the aorta's leftward position, its separation from the liver, and the presence of anterior branches outside the liver. It is important to note that pulsatility should not be solely relied upon the distinguishing this vessel, as IVC can be pulsatile in hyperdynamic state and tricuspid regurgitation, sometimes more so than the aorta. Dilated IVC might be present in the endurance athlete without an elevated right atrial pressure. Elevated intra-abdominal pressure can lead to collapse IVC despite elevated right atrial pressure. Solely visualizing IVC in the long axis can result in cylinder effect, where two-dimensional ultrasound beam may cut across the three-dimensional vessel at its periphery instead of the center, leading to the inaccurate measurement. Exclusively visualizing IVC in the short axis may lead to the error, such as confusing it with adjacent right atrium or being unable to accurately judge from the right atrium and locate the appropriate measurement site. About hepatic vein, subxiphoid view, place the transducer 1 to 2 cm below the xiphoid process with the probe marker oriented towards 12 o'clock position. With gentle tilt towards the patient right, capture the long axis view of the hepatic vein draining into the IVC. About coronal view, this view often results in the optimal waveform compared to that of the subxiphoid view. Position the transducer at the junction of imaginary line extending from the xiphoid process to the mid-axillary line, aligning the orientation marker towards the patient's right axis. Slide the probe slightly towards the patient head to visualize the liver diaphragm interface. Then tilt the probe towards to visualize the hepatic vein. So the first figure is demonstrating the junction of the imaginary line extending from xiphoid process to the mid-axillary line to visualize hepatic vein in the coronal view. The second figure is demonstrating position the transducer at the junction of imaginary line extending from the xiphoid process to the mid-axillary line, orienting the orientation marker towards the patient's right axis. Now about Doppler assessment. If encountering challenges in visualizing hepatic vein, the use of color Doppler imaging can assist in locating it. In normal state, the presence of blue color flow signifies blood moving from hepatic vein away from the transducer and into iris. Engage the pulse wave Doppler mode, placing the sample volume within the hepatic vein at least 1 to 2 centimeter away from the junction of hepatic vein and IVC, while being cautious to avoid venous junctions. Any of the three hepatic vein, that is right, middle, and left, can be sampled based on the axis. Uh, Ability of the patient to hold breath at end expiration helps. Holding breath at end of the deep inspiration or performing Valsalva maneuver blunt the wave. Examine the waveform of the hepatic vein. So first figure is showing the pulse Doppler mode with the sample volume, that is Doppler that pulse that with the sample volume position within the hepatic vein, approximately 1 to 2 centimeter away from the junction of the IVC. The second figure is showing the pulse wave Doppler tracing the hepatic vein in the abdominal preset. This figure is demonstrating pulse wave Doppler tracing of hepatic vein in the cardiac preset. Now about interpretation, the waveform of the hepatic vein comprise the two positive retrograde wave, that is A and V, and two negative antegrade wave, that is S and D, indicate the blood movement away and towards the heart respectively. Having simultaneous ECG assist in identifying each. The A wave corresponds to the P wave of the ECG, S wave aligned with the QRS complex, V wave occurs at the end systole, and D wave takes place after the T wave. The A wave is produced by the contraction of the right atrium during atrial systole, elevating right atrial pressure and propelling the blood back. S wave occurs during the ventricular systole as tricuspid annulus move towards the ventricular apex, causing the blood to flow from hepatic vein into IVC and the right atrium. generating antegrade S wave. The V wave occurring towards the end of the ventricular systole is a transitional wave resulting from the tricuspid annulus returning to its position, leading to the retrograde wave that can be either below and above the baseline. Finally, the D wave occurs during ventricular diastole as the tricuspid valve opens, allowing the blood to flow from hepatic vein into IVC and eventually entering right atrium, thus generating antegrade D wave. Normally, the amplitude of S wave is greater than the D wave. As the right atrial pressure increases alongside the RV dysfunction, tricuspid regurgitation, the amplitude of S wave diminishes and may even reverse the position itself above the baseline, leaving only D wave below the baseline. So, this is the waveform of the hepatic vein alongside the simultaneous ECG. So B wave is also demonstrating the waveform of the hepatic vein, where A and the V wave are the representing the retrograde direction, S and D wave representing the antigrade direction. So A wave is generated by the contraction of the right atrium, and it pushes the blood towards the right ventricle and towards the IVC. Then S wave is the right ventricular contraction. The blood is pushed into the pulmonary trunk, and the tricuspid valve annulus shift towards the cardiac apex. It decreases in right atrial pressure and then forward blood flow to the heart. Then the V wave, that is the end of RV contraction. The tricuspid annulus shift back to its normal position, increase in the RA pressure and retrograde flow of the blood towards the hepatic vein. So pitfalls are atrial fibrillation can result in the absence of A wave and diminished S wave without increasing the right atrial pressure. Other rhythmic abnormalities such as prolonged PR interval can lead to error in interpretation without simultaneous ECG. In conditions like liver cirrhosis, fatty infiltration, the hepatic waveform may exhibit blunting and loss of cardiac physicity. In case of substantial structural tricuspid regurgitation, a persistent reversal of S wave may occur, and this may not improve the volume reduction. It is important to note that while this pattern does indicate venous congestion and may be associated with damage to congestive organ, it might not serve as effective guide for deresuscitation. So D wave is representative of the tricuspid valve open, which results into passive blood flow from the liver towards the heart. Then, so first figure is demonstrated. The amplitude of S wave, that is more than, if it is more than the amplitude of D wave, then it is the normal waveform. Venous congestion is suggestive of amplitude of S wave is less than the D wave. Severe venous decongestion is suggestive of the reversal of the S. Portal vein Doppler. Unlike hepatic vein Doppler, the coronal view offers more distinct portal vein Doppler, even though it can access from the subsequent view. Position the transducer in the same region as when capturing the hepatic vein waveform. Slide it slightly in the caudal direction to observe the liver and adjacent right kidney. Fan the transducer anteriorly across the patient's abdomen to unveil the portal vein. About Doppler assessment, if locating the portal vein proves the difficult, employ the color flow imaging to pinpoint its position. In normal state, the continuous red flow is noted, signifying the movement of the blood towards the probe. Engage the pulse wave Doppler function volume over and main the portal vein for visualization. Decrease the Doppler scale to amplify the waveform amplitude and enhancing accuracy in calculating portal vein pulsatility fraction. To prevent the interference from the hepatic arterial flow, position the sample volume distally within the portal vein, avoiding the aliasing portion on color dot. Aliasing refers to the mixture of the color indicating higher velocity, that is hepatic artery. About interpretation, the portal vein waveform normally display continuous pattern with limited pulsatility due to hepatic sinusoids that dampens the linear transmission of right atrial. Portal vein pulsatility fraction is less than 30%. However, elevated right atrial pressure and RV dysfunction leads to venous congestion that can increase portal vein pulsatility fraction. Portal vein pulsatility fraction more than 30% but less than 50% suggestive of mild venous congestion. While if it is more than 50% with or without reversal, it indicates severe congestion. About potential pitfall, lean individual and athlete may demonstrate increased pulsatility index in portal vein without concurrent rise in right atrial pressure. In patients with the cirrhosis and portal hypertension, the portal vein waveform may display the low velocity continuous flow and in severe cases, hepatofugal wave flow that is complete flow reversal. Additionally, increased portal vein pulsatility fraction may occur due to arteriovenous connection despite normal right atrial pressure. Conversely, in some of these patients, hepatic sinusoidal pressure transmission from right atrium may be attenuated, potentially resulting in normal portal vein pulsatility fraction despite elevated right atrial pressure and tricuspid regurgitation. Comparing with prior imaging, if available, can be helpful. Respiratory variation in the amplitude of portal vein waveform might be mistaken for cardiac pulsatility, which by definition occur in each cardiac cycle. Simultaneous ECG aids in differentiation. This figure is demonstrating pulse wave Doppler tracing of portal. The another figure is demonstrating pulse wave Doppler tracing of portal vein with the hepatic arterial flow interface. This is a demonstration of pulse wave Doppler tracing of portal vein without hepatic arterial flow interference. Then this last figure is demonstrating portal vein pulsatility fraction calculation. If it is less than 30%, it is normal. Then venous congestion is suggestive of 30 to 50% pulsatility. If it's severe venous congestion, it's suggestive of more than 50%. Then about intrarenal Doppler. For venous Vexus assessment, the renal interlobular and the arcuate vein are selected instead of main renal vein and segmental vessel. This because the vein located within the renal parenchyma provide insight into effect of congestion and interstitial edema on renal perfusion. So we prefer interlobar vessel due to their easier identification compared to arcuate vein and their alignment in the parallel with the ultrasound beam. About transducer position, use the coronal window by placing the transducer at the junction of imaginary line extending from xiphoid process to the posterior axillary line with orientation marker directed towards the patient right axis. Pre-Doppler optimization, slide the transducer slightly in caudal direction to observe the kidney and adjust the depth to ensure proper visualization of the entire kidney. Next, utilize the zoom function to concentrate on the renal parenchyma, encompassing the cortex and the medullary pyramid. Now about color Doppler, engage the color Doppler and refine the box focus over the renal parenchyma to unveil the vessel. The blood in the renal arterial system flowing towards the transducer appear red, while in the vein flowing away from transducer appears blue. Troubleshooting. If the vessels are not clearly visible, confirm the abdomen preset is being used. Decrease the Doppler scale. Gradually raise the color gain until the flow becomes visible and being careful to avoid speckling. Adjust the transducer tilt towards the upward and downward and observe if color flow improves. Pulse wave Doppler. Position the sample volume of the pulse wave Doppler on the interlobular vessel to observe the intrarenal vein volume, which typically display below baseline with arterial waveform above. So this figure is demonstrating pulse wave Doppler mode with the sample volume position within the intrarenal vein. The second figure is showing the pulse wave Doppler tracing of intrarenal vein and intrarenal artery. Interpretation under normal condition, intrarenal vein Doppler exhibit continuous waveform with minimal pulsatility and the no interpretation. However, venous congestion results in the high-end pulsatility and interpretation in the waveform marked by distinct systolic and diastolic wave, signifying mild to moderate congestion. The phase of the cardiac cycle are identified with assistance of the simultaneous arterial wave. In case where venous waveform is obtained in isolation, an ECG can help. In severe congestion, S reversal occurs similar to that of the hepatic vein, leaving only D wave below the baseline. So this figure is demonstrating normal continuous waveform. Venous congestion is suggestive of biphasic distinct S and D wave. Severe venous congestion is suggestive of monophasic D wave only below the base. Now pitfalls, technically difficult to acquire optimal image compared to the hepatic vein and portal vein, especially in patients who cannot hold their breath and follow instruction. Not studied chronic kidney disease or renal transplant receipt. Now, Vexus grading system. The grading process in the Vexus is succinctly illustrated here. Briefly, IVC diameter less than 2 cm corresponds to grade 0, indicating absence of congestion. However, it is important to keep in mind previously mentioned pitfall regarding the IVC size. It is acceptable to proceed with the rest of Vexus examination if IVC appears circular and plethoric, suggestive of elevated right atrial pressure. When IVC diameter exceeds 2 cm, three grades of congestion are defined based on the severity of abnormalities observed in hepatic portal and intrarenal venous Doppler. In hepatic vein Doppler, the mildly abnormal pattern is characterized by the systolic wave smaller than the diastolic wave but still below the baseline. It deemed severely abnormal when the systolic S wave is reversed. Portal vein Doppler is considerably mildly abnormal with pulsatility ranging from 30% to 50%, severely abnormal when it is 50% or greater. Intrarenal vein Doppler is mildly abnormal when it is pulsatile with distinct S and D component and severely abnormal when it is monophasic and D of the only pattern. The absence of severely abnormal waveform but the presence of one or more mildly abnormal waveform corresponds to the Vexus grade 1. Single severe waveform aligns with the grade 2. And finally, two or more severe waveform indicate Vexus grade 3 and more severe congestion. So this is the grading system of the Vexus. If the IVC is less than or equal to 2 centimeter, then grade 0. If it is more than 2, then we need to examine further about further hepatic vein, portal vein, and then intrarenal Doppler. In the if this if hepatic vein if S wave is reversed, then then it is indicative of the severe congestion. In case of the portal vein, when the pulsatility index is more than 50%, then it is indicative of the severe congestion. Intrarenal vein uh, it's severe with monophasic D only pattern. Potential pitfalls and the cautionary notes. Vexus grading does not differentiate between venous congestion resulting from the volume overload and the pressure overload. It is essentially bedside tool to assess the severity of the organ congestion irrespective of the cause and the monitor the response to the decongestive therapy. Management should consider appropriate treatment for each patient and volume removal may not always be the best course of the action. Vexus should be interpreted with clinical context and integrated with other bedside information, including clinical lab and the image data. It should always be performed in conjunction with the cardiopulmonary focus. For example, in patients with the long-standing pulmonary hypertension and high Vexus score, caution is advised to avoid aggressive fluid removal as their cardiac output may rely on the hybrid. Improvement in the Vexus can sometimes be observed with the use of pulmonary vasodilator in the context of right ventricular dysfunction. Similarly, excessive volume removal in patients with high Vexus score without recognizing that congestion is due to pericardial effusion may precipitate tamponade by reducing intracardiac pressure relative to pericardial compression. Vexus only indicates the one component of hemodynamic circuit and should not be used as substitute for detailed hemodynamic assessment. Vexus is not tool to assess volume responsiveness. Vexus have been primarily investigated in the cardiac surgery patient and individual with the decompensated heart failure. However, its effectiveness in the different clinical subset of patients is yet to be throughoutly assessed, yet to ascertain its optimal integration into appropriate management strategy. Thank you, guys.